We have all kind of divided our roles, and most of my colleagues are engaged in the ICU, intensive care, taking care of pulmonary patients physically and right at the front end in the trenches. Some of us are in the background taking care of patients that are being managed at home and some other patients that have some COVID-related issues. So my discourse today will be focused on what I have observed myself, what I have experienced myself, and as I gain knowledge on that, as well as the experiences, observations, and expertise of my colleagues that are in the front line. Having said that, my intention today is to share with you the clinical overview of the COVID infection that we are facing over here, and how it affects the pulmonary and the respiratory system. I will not talk too much about the epidemiology, but I'm open to questions about that. And so what I've done in my template over here is to divide my presentation here into three parts. The first part is regarding the past. So what do we know about the past in this particular infection? Well, we have some knowledge and experience of the pandemic of 1918, quote unquote, not experience, but nevertheless knowledge of it, about what happened in that pandemic. And in this case, it started as a localized epidemic in China, and then now we are faced with this pandemic, which has hit us all. And our goal, hopefully, is that if we get our act right, and if we do everything that we are supposed to do at all ends and everybody plays their part, we hope to convert this pandemic into, again, some kind of a localized epidemic, and then let it go into an endemic stage, and then maybe some sporadic spurts here and there, ultimately controlling it, and hopefully at the end of the day, doing something to even eliminate it if we can. So that's the optimism pathway that we are hoping to achieve. From the clinical spectrum point of view, the way I look at it is this, that it's a respiratory virus known to spread by droplet infection, but also having some features where there might be an airborne spread too, as well as spread through fomites, as we call it, or contacts, especially contacts related to stainless steel and etc. So that exposure will lead or does lead into infection. And after the infection has set in any host, what we have found is that we face symptoms based on 3 or 4 stages, if you were to call it that. 80% of us are generally asymptomatic or get better on their own with some mild to moderate disease. And these patients are the ones that have upper respiratory tract symptoms. So it's not really any different than what we all face with, such as the flu-like illness or the any other upper respiratory tract viruses, except that in some cases it's a little bit more severe than the usual sniffles, etc. We have seen from data coming out of China and otherwise that there might be some other symptoms other than respiratory tract which may be associated with this exposure to infection stage. And some patients have been complaining of some GI symptoms also. There's been some recent data suggesting that there might be some skin manifestations too. I'm not sure of that validity of that yet. However, the most of the symptoms, as I understand, are related to upper respiratory tract. And when we say upper respiratory tract, it's generally nasosinusitis, sinus congestion, stuffiness, etc. And then it leads into the tracheal or the laryngeal elements where it's associated with increasing cough. And the mild to moderate symptoms that patients have while they are being managed, most of them at home, are associated with all this, with increasing cough and nasal symptoms, nasal stuffiness, and fever. What I've observed is that in the patients that I have followed, that the fever could be low grade. I lay a lot of importance to the trend of the fever. So we find patients that were, trucking along with 99 and then suddenly have a little creeping of their temperature and then show a high spike. And the high grade fever up to 103 has been observed in some patients. This is all associated sometimes with increasing cough. And the cough spasms are the ones that seem to be bothering the patients a lot more. And that increasing cough associated with some chest tightness, patients do complain of that while they're at home. That kind of increases their respiratory difficulty. That leads them into where they may feel that they are going downhill. Fever is spiking, respiratory change, respiratory difficulties occurring, difficult to breathe, and increasing spasms of cough. And that's when they get into the severe stage where they need to have some escalated care. Escalation of care is usually at the hospital level, where they might require supplemental oxygen support because their oxygen saturation or their oxygen is less. They are having what we call as difficulty in exchanging gas, air, carbon dioxide and oxygen, and therefore their oxygen gets low. And that's what leads them to the need for increased oxygen support. That escalation of treatment care, other than giving supplemental oxygen, also entails giving them oxygen by way of what we call as non-invasive ventilation. Non-invasive ventilation essentially implies that you're trying to give oxygen and ventilate the patient without actually intubating them. Intubating essentially meaning that we need to put an endotracheal tube and then put them on the mechanical ventilator. Once they reach a phase, unfortunately, where they do require mechanical ventilation, that's the time when with the fever, etc., they have now probably developed a viral pneumonia. So if you were to kind of step back a little bit and go from the start of the infection, it starts as an upper respiratory tract infection, what appears to be mostly nasal sinusitis, maybe some laryngotracheitis, etc. And then ultimately, due to progressive viral load, as we understand it now, or progressive inflammatory changes that are initiated by the viral load, these patients then develop acute inflammation of the lungs in the form of a viral pneumonia, and that viral pneumonia causes damage to the lung. The lung damage could be either what we call as diffuse alveolar damage, causing acute lung injury. These are all phrases that we use in our clinical spectrum. But essentially, physiologically, the lung loses its capacity to be an oxygen gas exchange organ, and therefore oxygen gets low and they require mechanical ventilation to give them supplemental oxygen. When that phase arises, this is generally called acute respiratory distress syndrome, and that's the time when it almost is at the time where all hell breaks loose. The ventilatory support notwithstanding, that can lead to other organ damage. And the most common organ damage that we have seen, or my colleagues have seen, and I have observed them peripherally, are related to acute kidney injury or acute myocardial damage. Along with it, there is some thought that there might be what we call as a little mini thrombosis occurring in blood vessels, and that can cause additional damage to the blood vessels of the lung, and then the whole lung behaves as if it is having a blood clots in the lung, and that can further reduce the capacity of the lung to oxygenate well. That acute lung injury diffuse alveolar damage, and the ARDS, or respiratory distress syndrome, that causes multi-organ dysfunction, multi-organ failure, and that is what ultimately increases the mortality of these patients once they are in that spectrum of their disease. That's the whole scenario of how this occurs. Our goal is that if we can keep the patients away from that particular scenario by managing them at home as best as we can, addressing their upper respiratory tract symptoms, hopefully 80% of them will recover, although the recovery is variable and depends on each patient themselves. As far as what we are doing about it, of course, the goal is that the upper respiratory tract symptoms can be handled with any symptomatic treatment, whatever works, but increasing your fluid intake and doing all the usual things that we do for any kind of a flu-like illness is generally helpful. There are no specific medications that have been proven to be helpful, although a lot of studies are being now in the pipeline, whether there are any medicines that will help us prevent from the exposure to the infection stage and help us prevent from the infection of the asymptomatic and mild stage to prevent it from progression to the severe stage. That's just being thought of. A lot of literature out there is floating, and we still don't know exactly whether that is going to play any part down the line. Giving any specific antiviral medicines to reduce the viral load of these patients, certain drugs have been tried. Studies coming out of China have not been very promising on that. It looks like there might be one particular drug that may be more helpful for reducing the viral load. And one hopes that if that drug does work out as part of the therapy, then the viral load will be reduced. If the viral load is reduced, then the chances of it causing inflammation in the lungs will be reduced. And if that happens, then the need for, then the stage of respiratory failure will be less. And if that happens, then the need for the ventilatory support will be less. And if that happens, then mortality will be less. So that's the whole goal of this spectrum. And last thing on my template today, before I open it up to discussion and share with you what your thoughts are, as well as share with you what my perspective is regarding going forward. So we talked about the past, we're talking about the present, now about the future. As far as the future is concerned, in my opinion, it's really going to be a public health battle. If we do everything personal protection wise, if we do everything social distancing, if we do everything related to personal protection, mask, hygiene, hand washing, etc., all that notwithstanding, the key to overcome this problem will be to identify the case, identify an infection when that occurs, isolate that person by the usual measures that we do, home isolation, etc., test whether that person has the infection or not, and then most importantly, so identify, isolate, test, and after that, try to trace down the contacts of that person so that we do a good contact screening. That, in my view, is the most important way of controlling the cohort of infection around us. It's almost like an onion whirl phenomena. You have the dot in the middle, which is the case, and then you start tracing their contacts immediately around them, and then try to identify the same things in those contacts, whether they have the infection, then test them out, and that cycle has to be repeated. That is the only logical way of controlling this pandemic and converting it to down the line from an epidemic to an endemic to a sporadic infection. That is my introduction.
Thank you. That was really informative. Thank you. We are getting some questions, so I want to move right into them. We have, and actually this is from Dr. Kathy Robertson. She said she rotated on your service back in the 90s. She's asking about thrombi, I'm not sure. I believe that the autopsies from abroad show microclots in lungs and CNS. I'm not in the direct care of these patients, but are you using TPA, or do you think anti-coags preventing the clotting is being used in New Orleans or anywhere else?
As I said, I am not personally involved in the care, and this is really dependent upon the teams that are using it. Some of them have been using anticoagulants prophylactically. Some teams have used therapeutic anticoagulants. And isolated cases I've heard where thrombolytics have been used. So it's really dependent upon practice patterns of what the physicians at the team and end of the team are using. I have had the privilege of reading about what others are doing, and it ranges from all these measures.
Okay. Another question. I've understood that up to 20% of those tested can have a false negative. Have you been seeing this phenomenon, and is there an explanation for this?
Yes, the false negative is a very important phenomenon. I've been seeing that pretty frequently at my end, at the peripheral community end. There are many reasons for it. First of all, any test that is done depends upon the operator variability of the test. So if I am to do a throat swab or a nasopharyngeal swab, and if I'm not doing it right, then I'm not going to get the right specimen. If I'm doing it myself, I may not be doing it as deeply as I should take that swab down. So one is the operator reason why we may have a false negative.
Okay.
The second reason may be just related to the fact of actually when we are doing it, because remember, this test essentially is a kind of a PCR genetic test that traces down the RNA of the virus itself. And the way it does it is it depends on what the viral load is at that time. So there are many reasons why that test may be negative. My experience is that when the test is negative like this, but however the symptoms are definitely of COVID, we should assume that it is COVID infection and maybe repeat the test later.
Okay, and is there a secondary test for those suspected to be false positive, especially in the context of case finding?
Yeah, there are tests that are done which may be related to different types and phases of tests based on PCR levels, and certain confirmatory tests are done at different levels at different labs.
Okay. I saw new findings to show permanent damage to liver and lungs found in recovering patients. Are these patients fully contracted COVID, or have these patients fully contracted COVID, and doesn't include even the lesser contracted patients as well?
Data on this is, in my opinion, very unclear. We are still in the phase of understanding the post-recovery of these patients. Clinically speaking, we have found that some patients, and in fact, I have helped some patients get oxygen. They need oxygen even when they are recovering, and they need it for a month or so at home. So one assumes that there might have been some residual damage to their lungs after recovery. It really depends on what recovery and what phase they recovered from. And of course, the host factors. The more, the healthier you are, the likely you are going to recover fully. The underlying lung disease, if you have some, then you are likely to have some residual damage. The element of damage depends upon the degree of exposure, degree of the infection. And in my opinion, it seems like that there might also be some residual effect, which is like which may be like a reparative effect or repairing of the lung when it's getting improved. So those are some changes that occur. Again, it's all an evolution of our knowledge. Remember, whatever I am saying is based just on a very limited experience of all this and some remote data from other countries. We still are trying to learn more and more. So the jury is still out as to what the long-term effect of this may be on the lung down the line.
Okay. Someone is asking, is there any lessening? Have you seen a lessening of patient visits since the first outbreak of coronavirus?
Lessening of patient visits related to?
It sounds like maybe they're asking, I guess, are we over the hump? Are we seeing fewer?
Yes, we are. I mean, the data that comes out, statistics that come out every day, and I'm following those that are at two phases. Those calls that I get from patients in the first week or so, I would, believe it or not, there would be about 30 to 40 or sometimes even higher calls that I would get. Most of them, of course, from my own patients, but sometimes from the relatives and so on. I'm getting less and less of that. It may be that that may be a function of the fact that people are now more knowledgeable, or the resources are more expansive, and they are getting their information and their counseling from somewhere else. That may be one reason. As far as the admissions to the hospitals are concerned and the patients that require ventilators, if we look at that parameter, the answer is yes, it looks like we have a better control of the numbers and the better control of the disease process now, and the numbers are reducing.
Okay. Just a couple more questions. Someone's asking about what are the current indications for starting hydroxychloroquine?
The indications are based on your own personal bias and philosophy. If you look at literature search on all this, you will find that there are isolated studies, mostly of small number of patients coming out of China and France and all, where they have used this. It depends on which phase of the infection you'll end up using. Whatever efficacy of this drug has been shown in these small studies, which are essentially not truly scientific studies. They have, A, numbers are small, B, there are a lot of limitations on that study, on those studies, and have not been truly peer reviewed. We have found that if they have given this drug in the early phases of either asymptomatic to mild to moderate, they have claimed that they have that the patients have done well and have been preventing from getting into severe disease. Again, I say that with a definite caveat over here, that these are very small studies and are essentially based mostly on mega anecdotes. Mm-hmm. As far as using this drug when the patient is severely ill, is in impending respiratory failure, or has developed respiratory failure and ARDS, there are no studies that show whether that really helps or not. So we are very skeptical to give this drug at the later phase of the disease, because there is really nothing there to support that. To answer the question a little bit more specifically, patients are being given this drug by practitioners alone based on their preferences and their own judgment. And I have been asked by many patients to give that. Some of my patients had been using that drug for other diseases and have thanked me that I had put them on a year ago for something else, and now they seem to think that they'll be protected by it. But that's all I can say on that count. At the moment, I think, yes, There is some noise over there about this drug, whether this will really pan out to be a drug that we can use to prevent in the phase before at the time of exposure to get into the infection phase, or will prevent the progression of the asymptomatic or mild disease to severe. That jury is still out.
Okay, just a few more questions. Have you seen any cases of a patient being infected twice? And what are your views on immunity?
Personally, no, I have not had any of my clinical experience. And again, mine is limited to my own cohorts of patients. I have not seen anybody that can confirm that they've had it again. No. As far as immunity is concerned, there is some preliminary data that suggests, I think it's, if I'm not wrong, it's not human data, it's animal data that suggests that there might be some long-term immunity of this for a year or two or more. We don't know much about the degree of, we don't know much about the duration of the immunity. It is assumed that that once you have it, you will at least have the immunity for that particular strain, and unless there is a mutant strain, etc., that most likely you will have an immunity for a year or two. However, all that is very much unknown still.
Okay. And somebody's asking, is it true that diabetes is the worst comorbidity, even worse than asthma? Even more than asthma?
Yes, it is. At the moment, the way I understand the comorbidities, I would look at it into three groups. The comorbidity due to lung disease. So if you have an underlying lung disease, and generally if you have an underlying lung disease and it affects the lung itself, such as COPD or fibrosis of the lung, then and if you land up getting acute respiratory failure, then your mortality is definitely going to be higher, or not definitely, but maybe higher, sorry, because of the underlying lung disease. So that's one comorbid condition. The other comorbid states would be those where you have a metabolic derangement, and of that, the biggest example is diabetes. Diabetes is one of those systemic diseases that one can have. It affects almost all the major organs of the body, and it does affect the blood vessels of the body. And because of that, I think that one of the reasons why diabetes is now in the higher list of comorbidities that affect the mortality of the patient is because of the effect of diabetes on the blood vessels and the microvasculature of the body itself. The third comorbidity are those that are those that are immune compromised. For example, systemically immune compromised, those who are cancer patients or who are on immunosuppressive drugs and all, their general immunity is low, and that's why they are more prone to increased mortality with comorbidities. Asthma per se is a lung problem. So from that perspective, the reason it is a comorbid condition is more related to the fact that the symptoms of asthma with difficult breathing, wheezing, and increasing cough are almost the same as the COVID symptoms are. And therefore, the symptoms get exaggerated due to that.
Okay. All right. And final question, have you observed the use of plasma from recovered patients being used to treat current patients?
I have been watching some centers doing that, and again, isolated anecdotal experiences show that has helped in some cases, but nothing has come out on a concrete basis that is supported by strong science yet.
Okay. All right, y'all, that's really all the time we have for questions today. I do want to let you know that this webinar will be posted to our website and our social media channels, and we will be hosting more webinars in the next coming weeks. Our next one will be on Monday. And you can find that information on our website as well. Crystal? Oh, hold on one second. Oh.
I think she's mute.
Yeah. Well, sorry about that, everyone. I'm not sure what's going on with Crystal's audio.
Yeah, her audio has been muted, I think.
Oh, I'm sorry. There I am.
There we are.
Sorry, my child came bursting in here and I forgot that I muted my microphone. Thank you guys for tuning in. Thank you, Dr. Ali. That was a really wonderful presentation. Thank you for all of the information, and thank you to all of you who participated and asked questions. Please tune in on Monday for Dr. Ben Springate, who will discuss the mental health consequences of coronavirus and strategies to cope with those. And that's all we have. Thank you again, and everyone take care. Be well.
Thank you.
Thank you all.